Emma's going to discuss the work currently being done by the working group for all Wales medication policy and procedure. This is still a work in progress, but he will detail the vision and the progress that's been made so far. Over to you, Emma.
Thank you very much. Prynawn da, everyone. Diolch am y gwahoddiad I ddod I siarad â chi heddi. Good afternoon, and thanks for the opportunity to come and speak with you today. Could I have the slides up when you're ready, please? Perfect, thanks there. So yes, I'm Emyr, and as we mentioned, I'm a pharmacist. So obviously, being a pharmacist, my interest is in medicine, and particularly my area is community health care. So basically refers to trying to optimize the use of medicines in settings outside hospital and your traditional primary care settings, if you like. So I'm interested in the domiciliary care setting, obviously, because I'm speaking today. Also the care home setting and settings such as hospices as well. So feel free to chip in as we go along. I'm happy to take questions and comments as we go, or pick them up at the end. I don't really mind. I'll try and keep my eye on the chat. Next slide, please, if you can, Claire. Perfect, thank you. So you don't need me to tell you that the number of people in Wales who have health problems requiring both health and social care is increasing. So if you look at these graphs at the top, what that shows is that we're getting less of that narrow peak at the top as we move forward, which shows that more people are living longer. So if we look at the list which show in 50 years time, or less now, there's going to be an additional around 9 million people aged 65 and above in the UK, which is roughly the population size of London. So this aging population, and also when we see these graphs, the change in structure of the population, that's going to bring challenges. The economy, obviously, and services that we offer, and also to society at both a local and national level. So what does an aging population mean? Well, it means that more people are going to be living with complex health needs. So historically, maybe people were living with one chronic disease condition, and that was probably would have eventually they would have died from that chronic condition. But now, with more medicines and improvement in healthcare, that we are seeing people living longer with more than one long-term health condition, and we refer to this as multimorbidity. So they live with a multiple of chronic diseases, which will need a combination of both health and social care services to support these individuals. So if you look at medicines then, within NHS Wales, we spend a hell of a lot of money on medicines, around 800 million on medicines in the community, and we dispense probably by now over 80 million items. So we do use medicines at a substantial scale. And if you compare now with 10-15 years ago, we've doubled the amount of medicines, that number of items that we dispense. So it does show that increasing the population of frail older people leads to people taking more medicines, more repeat medication, and we know that from the evidence that taking more medicines leads to higher risks of adverse drug events, and also leads to higher use of NHS and social care services. So the picture at the bottom there is trying to illustrate polypharmacy, and I'm not sure you've heard the term polypharmacy. So that is the use of multiple medicines to manage the complex needs that we're seeing our individuals with. And the risk of polypharmacy does lead to a higher chance of hospital-related admissions. And polypharmacy can be either appropriate, so people who are having multiple chronic conditions will need multiple meds to treat those conditions. But the area we're particularly interested in is the inappropriate polypharmacy, where in the frail elderly individual, less is maybe more, and we as healthcare professionals keep on prescribing and dispensing these medicines where they may be causing more harm than good. Next slide, please. When you're ready, please, Claire. So we know we're churning out all these medications, but is it making a difference? Well, some of the evidence we have that up to 50% of all the medicines that we as healthcare professionals prescribe, or what we think we're prescribing, patients don't take them half the times as intended. So there's a big gap in terms of what we think we're prescribing and people are taking as healthcare professionals, and actually what in practice they are taking. And also we see over 1 in 10 of all medicines related incidents following a discharge is due to non-adherence. So people are not taking their medicines as appropriate. And there's a combination of reasons that people don't take their medicines in their own homes. Could be intentional or unintentional or non-intentional. So if we think of the intentional reasons for non-adherence or not taking your medicines, it could be due to concerns about the value of the medicines or how effective they are, particularly when we talk about chronic medicines. So if you think about taking a tablet for your high blood pressure or your cholesterol, then by taking that tablet, you don't necessarily feel any better, but where you're taking that medicine to prevent something from happening in 10, 15, 20 years. So it's hard for people to become committed to follow that regime when it's a lifelong process. And also taking the medicine is an inconvenience. So again, an example could be you've got an elderly lady who wants to go out shopping and then intentionally doesn't take her water tablets because she doesn't want to go to the toilet, and she doesn't want to let that tablet stop her from doing what she enjoys doing, like going shopping or visiting friends. So she ends up not taking the tablet and ends up with fluid overload and potentially a hospital admission. So we've got to be better at understanding and what patients and individuals want from their medicines. And also there's unintentional reasons for people not taking medicines, and that could be down to healthcare professionals not giving them the right information in an easily understandable format. They may have difficulty reading the labels, so that they might be making mistakes when they don't realize they are, or that it could be something as simple that they're not non-adherent because they can't open the container. So there's a multiple of reasons why we find individuals with non-adherence. So the important thing is, as healthcare professionals, that we give older people and their carers and their care workers the correct information about their medicines. Next slide, please, Claire. Brilliant, thank you. So I've mentioned in the title that what we're looking at is medicine optimization, and medicine use can be complex, we know that, and ensuring people can take their medicines effectively is and will continue to be a challenge for health and social care services. And when we talk about medicine optimization, we think of that person-centered approach to medicines where we focus on outcomes. So the outcomes that's important to that individual. And we base it on best evidence and what's practiced routinely. And it should be the aim, medicines optimization should be the aim of everyone who's undertaken any role with medicines, whether it's in health or social care, that we get the best value out of medicines. And in March 2017, the World Health Organization launched its third patient safety challenge, and understandably it's probably dropped off the radar a bit due to COVID, but the challenge was medication without harm. So it was an ambitious goal of reducing avoidable medication harm by 50% worldwide over the next 5 years. And the World Health Organization looked at 3 key actions. So they looked at high-risk situations with medicine. So when you've got a risky drug, which in the majority of the population, it's probably okay. But when you put a risky drug in a risky patient, what I mean by that is if a patient's got a kidney problem or if they're particularly frail, then when you've got a risky drug in a risky situation, that's what tends to lead to hospital admissions. The other action was polypharmacy, which we've talked about, and the challenges around multiple medication. And also the third main action point, and I'm sure you can all relate to this, was that transition of care. So when we're handing over care from one organisation to another or across settings, we know that this is not done very well, and it can lead to problems. So the challenge, the WHO challenge, was taken up by UK government and Welsh government, and it's led to looking at different technologies, so trying to roll out electronic prescribing systems, looking at IT tools to make prescribing safer. So all that's good. However, medication safety extends far beyond the NHS into social care and other sectors, and very little really has been done looking to improve medication safety in social care. And we know that the working environment in social care remains hugely pressured, and that's only going to increase the likelihood of human factors that lead to errors. And we know that most errors, when it comes to medicine, or any errors in particular, result from the system, not the individual. So the system, by means of inadequate training, long hours, medication packaging looking the same, lack of appropriate checks in place. So there's a number of work streams that we need to look at in order to optimize medicines in social care and make it as safe as we possibly can. Next slide, please, Claire. Thanks. So evidence-based medicines, as pharmacists, we tend to be a little bit obsessed with evidence, that everything we do must be based on evidence to inform the decisions that we make. So we like to combine clinical experience, because that's one of the main way that we come to a decision. We also use evidence from literature, so clinical trials, and also, most importantly probably, is patient values and patient perspective, what the patient wants when it comes to their medicine. And the research out there, when it comes to older people and their medication related needs, it tends to fit into three main areas. If it's in having timely access to medicine, so having the older person ordering, collecting their medicine, that tends to be a challenge. Ability to adhere to medicines, which we've already touched upon, that non-adherence, whether it's intentional or non-intentional, and the outcomes, and that's the main thing, the outcomes, whether it's negative or positive from taking the medicine, and that will dictate whether the individual are keen to continue taking that medicines. And looking at evidence, even though the majority of medication are taken in a person's home and also being increasingly administered at home by care workers, all the studies, or pretty much all the studies around medication safety, is conducted in hospital settings. So we don't really know what happens in people's homes, how carers cause, or more importantly, prevent medication administration errors. We're very concerned about care workers making mistakes when it comes to medicines, and rightly so, because medicines have the potential to cause harm. However, we need to keep this in perspective, that people will make mistakes. It's the human factor. However, having a carer in to support with medicine is a hell of a lot safer than getting the patient themselves to do it. I dread to think if we'd actually did a study of a patient taking their own medicines, we already know that 50% of the time they won't take it anyway, and of those 50%, there's be a lot of mistakes happening. So I think it's important that we keep that in perspective, and the importance and the crucial role a care worker and care workers do when it comes to supporting with medicines. And care workers will make the full range of errors are same as any other healthcare professional. So we've got nurses who make errors, pharmacists, doctors, and it's always going to be human nature to make errors. But there's been very few interventions trial to support carers to reduce these errors in their own homes. And of the limited evidence that we have, it tends to indicate that formal and informal carers may lack training or knowledge in certain areas. And again, that's something we can do something about. So even though I've focused on this slide about errors, I think what I wanted to get out of it, the benefits that care workers and social care supporting with medicines far outweighs any risk when it comes to any errors. Next slide, please, Claire. Thank you. So this slide is just trying to really do a bit of myth busting and trying to clarify some misconceptions when it comes to the legal framework of medicines in the community. So we always have the conversation, is medicine a health or social care responsibility? But there's no single organisation responsible in law for managing medicines for people receiving social care in the community. Each health and social care organisation will have their own responsibilities, and that co-production is obviously key to the Social Services and Wellbeing Act, and also the principles of prudent healthcare, and we need to promote that integration between two sectors as to the greatest extent that we can. So there's no point really saying, is it a health or a social care task, because medicine is too broad. You know, medicine covers from taking a simple paracetamol once every couple of months for a headache to, you know, an intravenous chemotherapy injection. You wouldn't expect a nurse to administer a paracetamol for a headache, but you definitely want a nurse involved in administration of something as complex as that. So everyone has their own roles, and we're trying to promote that personal care, that the individual takes as much responsibility for their own medicines as possible. So if we go through some of these pictures here, so the top left is trying to illustrate the prescriber. So usually in the community, we're talking about the GP. So they have duties to prescribe, obviously, and monitor what they prescribe, and also evaluate how effective they've been. And also they have a professional duty to improve communication when it comes to changing a person's medication, and we know that doesn't always happen, and it can be challenging. So as prescribers, they will have to follow their own regulated professional standards, which is the General Medical Council. So the middle picture there tries to illustrate the supplying pharmacist or the dispensing GP or whoever supplies the medicines. So pharmacists have a duty under the Medicines Act to ensure that we dispense medicines in line with what the prescription says. And also we need to take into account any support that individual needs with medicines, for example, under the Equality Act. So we've got responsibility under the Equality Act as dispensing pharmacists to ensure that if the patient or individual is struggling with their medicines, we can make some adjustments to ensure that, you know, they're not disadvantaged when it comes to taking their medicines. So that could be providing larger labels, so for people with visual impairment. They could be changing the lid of the bottle, or providing a compliance aid to help an individual. So there's a range of interventions that the pharmacist can do, and the expectation under the Equality Act to make these minor adjustments. So when we move on to talk about the care workers, they can legally give medicines under the Medicines Act, provided they're suitably trained and in accordance with the prescriptions. And I think this is where some of the misconceptions happen. So there's no legal reason stopping a trained and competent care worker to administer patches, eye drops, controlled drugs, and there's nothing to say that, you know, they have to administer it from a compliance aid. And trained and competent care workers don't need to be signed off by healthcare professional first. There's no requirement for that. It's the responsibility of the employers to sign off their care workers. So I hear a lot of different interpretations of the role of care workers, but if we strip it back down to the law, then they can legally give medicines under the direction of a prescription. So finally, just very quickly then, talking about commissioners, they obviously have a duty under the Act to ensure that they assess and commission care appropriately according to an adult's need when it comes to medicine support. And providers have legal duties under the regulations to ensure that they meet the medicine support needs of that individual, and they have a duty to ensure that they employ enough staff and competent staff to support with medicine. So I think it's worth clearing that up, because there's a lot of, as I said, I hear a lot of myths and misconceptions out there. Next slide, please, Claire. Perfect, thanks. So next, to look at some of the policy drivers in this area. So back in 2007, the Royal Pharmaceutical Society produced some guidance on handling of medicines in social care, which they set out some principles and good practice covering the legislation aimed at care services and managers and care workers in settings. And in around 2016, then, the Department of Health asked NICE. So NICE is the National Institute of Health and Care Excellence. So they asked NICE as an organisation to provide some evidence-based guidance on the management of medicine in this area. So for people who are not familiar with NICE, so NICE as an organisation aims to ensure that we give fair access to good quality-based care and uses evidence to inform their decisions based on what works and also what is value for money. So I think it's fair to say that most people around healthcare are aware of NICE, but I think NICE have got a bit of work to do to make it to raise the profile in social care. It's also worth noting, and because of my work with NICE, I'm a fellow with NICE, so all NICE guidelines apply to Wales and are subject to Welsh legislation. And even though they are written in context to English legislations, we are looking, and we've got a group set up to look at a project to see how we can slightly adapt NICE guidelines to make it applicable for the Welsh legal framework and context. So based on the NICE guidelines and Healthier Wales and Social Services Wellbeing Act, in 2019, around that time, a lot of the health boards were actively working with their local authority partners to review existing policies based on, as I said, these drivers. So it was an opportunity then to develop some national guiding principles. So that's the third document there. So these were launched October 2019 and developed in partnership with heads of adult services and NHS colleagues to try and provide a template for the development of medicine policies. So medicine policies across Wales, if they take account of these guiding principles, should be developed in a consistent manner. So what we try to do is define different levels of medicine support. So we all have that common terminology, from a patient being fully independent and not really requiring any support at your level 0. Then you move to level 1 when the individual is directing the care worker, to level 2 when that responsibility for administration shifts from the individual to the care worker. And we also defined specialised route that we wouldn't expect a care worker to routinely administer, but they could potentially if it was delegated properly from healthcare. So the aim was to have everyone on the same page and set some foundation. So it was hoped at some point, if we can have consistency between health board footprints, then we could at some point go down the route of a Once for Wales policy, and I think that would be that would be a massive achievement. And consistency in policy nationally then will inevitably lead to the ability of us to roll out some more national training to support the sector, and if everyone is doing the same. So included within these principles then, we provided information based on NICE guidelines on monitored dosage systems, so blister packs, compliance aids, whatever you want to call them. We just reinforced the Royal Pharmaceutical Society guidance as well, that dispensing of medicines in original packs rather than these blister packs when care workers are involved with administering medicines would be the gold standard. And as we've seen over the pandemic, the reliance on blister packs or MDS trays has been a bit of a challenge for providers, particularly with a number of pharmacies struggling to keep producing them due to workforce challenges. So the first thing that pharmacy will stop doing when they have workforce challenges is things that they don't get paid for, and they don't get paid for producing MDS, which that you could understand due to everyone's challenges. So there's a lot of work again to be done around that area. Next slide, please, Claire. So work in progress. So even though we've got the nationally agreed principles, I think we've got still a lot of work to do from the policy side of things. The work we did with heads of services, we had an agreement that they would support the delivery of level 1 and 2 medicine support, providing it was ancillary and incidental. So if there's care going in there anyway, and they would be happy to support with medicines. However, we know across Wales that not all policies allow care workers to administer. Some have a policy of prompt only. So what we're trying to work on is some consistency across Wales. And there is some disconnect in what the levels say and what care workers are actually doing in practice. So going back to the prompt only policy, now we could have a prompt only policy in place, but actually in practice, dom care workers may be administering at a level 2 in best interest of that individual. They probably just go in and do things in the best interest of the individual. So we don't want to be having to put words in people's mouths to make them fit in a particular level, and I think that's what where we get the risk to patients and care workers as well. So maybe the aspirations is, and this NICE doesn't mention levels of support, so I think maybe we need to, and I think the levels are helpful, but I think in future it would be great if we could just focus on that personalised medicine support, that we describe what that individual needs when it comes to medicine, and not having to label them with a number or a level. But also we need to make sure that we have a policy that reflects what's happening in practice. And we're aware that, you know, if we've got policy that doesn't, then the commissioning process and policies are not fit for purpose if people have to work outside them. And also mentioning commissioning there, we have to make sure that it's not just, as you all agree, I'm sure, that it's not just about cost, isn't it? It's the time it takes to safely deliver medicines. And we've mentioned polypharmacy at the beginning. Yeah, the more complex people we're supporting at home, the more medicines they're going to be on. So we just need to make sure that, you know, we give enough time to do it, particularly if the policy driver is to move away from, as I said, compliance aids into original packs. The other pieces of work we're looking at is medication only calls. So again, the discussions was around that ancillary and incidental support that local authorities agree that they deliver level 1 and 2. But what happens in that gap then, and the work and the discussions we had, the expectations then is for healthcare to support with the commission of the medicines only calls, and I know we are seeing battles locally to try and agree some funding for these important group of patients, and they're probably not a huge number that have just support needs with medicine and no other personal care calls, but they are an important group of patients that have a risk of slipping through the net if we're not careful. So again, what we're calling out for is some agreement and some consistency. And finally, training. Sorry, can you move back one more? Sorry, yeah, training. We're looking to develop a more consistent approach to training, and we feel that training of staff is fundamental to all of this work, especially with the policy driver. And when we haven't got access to robust training, then there'll always be a reluctance to work in line with the national policy. And I think you'll all agree as well that it would be beneficial if we can do training, and if training and competency can come as a standard package across Wales, whether it's part of a national competency framework, because we have examples of providers having clients in different local authorities having to complete a number of different training packages, and it doesn't really make sense, does it? So we are looking to work closely with Social Care Wales, Health Education Improvement Wales to link in training when it comes to medicines with qualification frameworks and the career pathway for a care worker. And I think providers just want some steer and to be pointed in the right direction when it comes to medicine. And the aspirations, I think, from the working group that we have is there a way to develop a medicine training passport approach for health and social care staff, so we can be assured that all care workers work to a similar standard and trained on the same level, regardless of whether it's commissioned by Health Board or local authority, and maybe using the success of the manual handling maybe as a roadmap to do similar when it comes to medicine training. Next slide, please. So thank you. So I've spoken much longer than I intended to. Sorry, but it was a whistle-stop tour of some of the background to medication. So we looked at some of the background to medicines. We looked at the policy drivers and hopefully some of the future work we're looking to do. So diolch yn fawr am wrando. Hapus I gymryd unrhyw gwestiynau now. So happy to take any questions and thanks for listening.
Diolch yn fawr iawn, Emyr.